Great. Hi, welcome everyone. Thank you for joining the Fertility Circle event today. A quick note from us, in case you don't know, Fertility Circle is a new app to support anyone trying to conceive, and we have brilliant events, content and a fabulous community. So check out the chat walls and other events, come say hello. And of course, we have over 40 brilliant resident experts who are all fertility providers and experts in their own field from a range of disciplines. And today we're delighted to have Rachel Sherriff join us. Rachel is, of course, one of our resident experts and is an acupuncturist specialising in fertility support. Rachel runs Oxted Acupuncture in Surrey and holds a diploma in fertility acupuncture and working to help treat more complex conditions around fertility and pregnancy. So Rachel, welcome, really lucky to have you today.
Thanks so much, thanks for having me.
And you're going to be speaking on female fertility tests today. So I think without just a little bit of admin from me, we are recording, so please also keep yourself muted just to avoid background noise, and at the end there will be time for questions. You can also post those in the chat channel, which I will be monitoring, and we can store those up to ask Rachel at the end, but otherwise over to you, Rachel.
Thank you so much. Hi everyone, thanks for joining us. So we're going to be talking about female fertility tests today. So the main key areas are the pillars of fertility. So we're going to talk about the different areas of fertility, what important things we need to look at what point you should consider fertility tests or investigations, the common hormone tests and what they can tell you, and then we're going to have a look at surgical investigations and when you might want to consider those. And then finally, we're going to finish up with recurrent miscarriage and IVF failure and where to turn next. So we're going to start with the more simple tests and lead into the more complex. So I actually have a slideshow to play. So I'm going to screen share. So just bear with me for 1 second, because it will be much easier to understand with the slides. Can you just confirm that I'm sharing that?
That's looking great, Rachel. Yeah, perfect.
Okay, give me 1 second. Okay, fantastic. Okay, so this is like an overview of fertility. So they're what I call the fertility pinch points. So if you're struggling to conceive, it's really important to work out which part of the process is causing the issue. So often unexplained infertility is not unexplained. It's just that the issue hasn't been investigated properly yet. So first of all, we talk about egg quality. So this is actually the only fertility test that you can't do, which is why I'm just going to talk about it quickly first. So no test exists to check your egg quality. So we know this declines with age, and we know that lifestyle factors and hormone balance will have an impact. So the best thing you can do whilst you're having any fertility investigations is to always think about egg quality and what you can do to help improve it. So putting things in place within your life to make sure that egg quality is the best it can be. Now, that's a whole nother webinar, and we're just going to talk about the testing side of things, but everything else can be tested and potentially eliminated as a cause of fertility issues. So this first part on this first slide, where we're talking about the eggs being recruited and developed, these will be affected by hormones. So the best thing you can do to impact your egg quality is to make sure your hormones are balanced by lifestyle changes and by getting them checked, which we're going to come to talk about. The next part is ovulation. So we need to make sure ovulation's occurring. Obviously, that's relevant for natural fertility. So if you're not ovulating, you won't get pregnant. You may still have a period. So it's possible to have what's a bleed. It's not technically a period, but it's a bleed. It may be a light bleed or an irregular bleed. But it's possible to have that and not actually be ovulating. So again, we're going to look at some of the tests that can work out whether ovulation is happening. The second important part is whether the sperm is able to get to that egg. So first of all, you need to have the correct type of what we call cervical mucus. So your mucus changes throughout the month, and if you don't see that stretchy egg white type of discharge, then it might mean that you're not ovulating. So this cervical mucus is really important to actually help the sperm enter the uterus. If you've not got the right type of mucus, then the sperm just won't be able to enter. The sperm then obviously needs to be able to reach the egg, so your fallopian tubes need to be clear. Again, we're going to talk about some tests that can check whether your fallopian tubes are clear, but you can actually have blocked fallopian tubes and no symptoms at all. So important to work out whether that might be something that's causing you an issue and whether it's worth getting checked. Once the egg and the sperm meet, we need to make sure that fertilization is happening. So I'm not going to talk really about sperm today because we're really discussing female fertility tests. However, it's important to remember that sperm can be checked under a general sperm analysis and appear to be healthy. However, on deeper analysis, something called a sperm DNA fragmentation, you can have something called oxidative stress or damage caused by lifestyle factors or physical issues that can cause damage to sperm. And evidence is starting to show that sperm that has this oxidative stress damage to it can not only cause failure to fertilize, but also failure to implant in IVF cycles or an early miscarriage as well. So this has more far-reaching effects than we previously realized. So fertilization occurring, obviously key factor, and then implantation. So if you're lucky enough that your egg has fertilized, you've got an embryo, how is that implanting? Is the uterine environment really supporting that process? So we need to make sure the uterine environment is free from any infection, any inflammation, and whether your immune system is allowing implantation to happen. Again, we're going to talk more in depth about that in a bit. And then finally, if implantation starts to occur, how the embryo and the placenta then develop. So in order for this to happen, you really need to have healthy blood flow to the uterus. And also, again, your immune system needs to allow that to happen. So just from looking at this slide, you might be able to work out some areas for you that you think might be causing an issue. Bear those in mind, and then as we talk about the tests, we'll refer back to this as well, and you can see how we can work out what sort of tests might be suitable for you to have. So all these areas need to be assessed and checked, but quite often some of them are skipped over or they're only scratched at a surface level. So a prime example of this would be with sperm testing again. So the NHS will only do a basic sperm test. They won't do any sperm DNA fragmentation testing. That has to be done privately. But also for things like miscarriage, unfortunately, the NHS say that you have to have suffered 3 losses before they will look more in depth at what might be causing that. So whether that's immune issues or blood clotting issues, you can't have these tests done immediately. Certainly if you're under private care, it could be looked at more quickly. So that's just an example of how sometimes the surface level is only really scratched, and there's so much more we can do to look at fertility testing. So at what point should you consider having any tests? So my personal opinion is that you shouldn't be going into IVF without having certain tests done. I think quite often you walk in the door of a clinic and it's just kind of assumed that you're happy to plow on with fertility treatment, whereas quite often you're in that in-between stage where you want some help to work out what's going on, but you're not sure about IVF, and you have that consultation and you come out thinking that your only option is IVF. And this is when I'd really encourage you to start educating and empowering yourself to take back control of your fertility journey. So just to dig a little bit deeper, some of the tests we're going to talk about can be done by your GP on the NHS or by a fertility NHS specialist. And some of them will need a specialist fertility clinic or to be done privately. So again, I'll let you know which is which. So we're going to start by talking about some of the more common and what I would call basic level fertility tests. And it's really important when we're looking at these that we remember that we don't look at a single hormone. They all affect each other, and we need to think about the overall hormonal balance and not just a single hormone. So the following tests are all tests that can be done by your GP on the NHS, and these first lot of tests should normally be done between day 2 and 5 of your cycle, and they're often the first port of call when you go to the GP. But quite often something I see is that the GP will only select 1 or 2 of these hormones to be tested and not doing a full hormone profile. So if you really want to get to the bottom of your hormone balance, which will in turn affect your egg quality, then you need to be making sure that this full list of tests are completed before you start scratching any deeper. Sometimes a GP will have a specific interest in fertility, and therefore they might pick up on some of the imbalances. However, often you're better off kind of showing these results to a fertility specialist for some interpretation. As GPs, they do tend to be more general practitioners, and they might not often be faced with hormone imbalance issues a lot. So again, sometimes just worth showing them to someone who's a little bit more specialist. So the first one we would say to get checked is something called follicle stimulating hormone, or FSH, which is more commonly known. And this is measured to basically check how your ovaries are working. So if your ovaries are having to work extra hard every month to grow your follicles, then you might have high FSH. And also if you're in perimenopause or menopause, or menopause rather, your FSH will be high. But it's also really important to measure against the next hormone, which is luteinizing hormone, to assess the possibility of having polycystic ovaries. Polycystic ovaries is something I'll talk a bit more about in a bit, but it's possible to work out whether that's maybe a factor by comparing FSH and LH. And also, if you are about to consider IVF, having your FSH tested gives a clinician an idea as to how suitable you would be for IVF. So some clinics will only treat women with a lower FSH for, whether that's for statistical or ethical reasons. Some clinics just have certain rules that they won't treat women with FSH over a certain level. So really common and important thing to get checked. And if it comes back abnormal, then something to bear in mind is that other hormones, like we said, they all interplay. Other hormones may affect this. So always worth getting your thyroid checked if your follicle stimulating hormone comes back as higher than the GP would expect for your age. Thyroid function can have a big impact on follicle stimulating hormone. Luteinizing hormone, next test. This causes your ovaries to release an egg during ovulation, amongst other things, but this is the main hormone that's at play. And this is also the hormone that when you use ovulation predictor sticks, so by that I mean the sticks that you wee on to work out whether you're ovulating, this is what's measured on those sticks. So again, measured to work out whether polycystic ovaries might be a consideration. So generally, women with polycystic ovaries will have a really high luteinizing hormone level, often much higher than follicle stimulating hormone. And this also means that the OPK sticks can give you an inaccurate result. So they might give you a high peak fertility reading that goes on for longer than it should. So if you're using those sticks and you're getting peak fertility for more than a few days, then this might be worth getting checked. Also, this can affect egg development and follicular development. So polycystic ovaries will have an impact on your egg quality. So again, if your luteinizing hormone is a little bit too high, could be impacting on your egg quality. Next test, again, a really key one, and this is estrogen, commonly known as estradiol or E2. You might see it on a test result. This is like our main female reproductive hormone, and it's produced by your ovaries. And as you get older, the amount of estrogen you produce when you go into menopause will reduce. Quite often, if you're perimenopausal, you may have excess estrogen. It's a bit of a myth that estrogen just declines over age. That's not really how it works. But this is responsible for thickening your uterine lining, ready for implantation, and then really importantly, the maturation of your eggs and ovulation. So by testing your estrogen level, we can look at numerous things. We can work out how well your ovaries are functioning and potentially have some idea as to what your egg quality may be. Again, there's no definitive test, but this will help us to make an overall assumption. To diagnose or eliminate certain conditions such as polycystic ovaries. And also, again, interplaying with hormones. If your estradiol is high, then this often suppresses your follicle stimulating hormones. So if you have a high estrogen reading and a low FSH, then there could be some inaccuracies with your FSH level going on there. And again, clinicians use this to determine prior to fertility treatment, or when you're in fertility treatment, how your ovaries are responding as well. So, for example, when you are stimulating in an IVF cycle, if your estrogen is too high, then this is a sign that you might be about to hyperstimulate or already hyperstimulating. Prolactin, I'm not going to talk too much about prolactin, but if it's elevated, then it can sometimes mean that you won't ovulate. This is the hormone that is produced after birth, which is why breastfeeding women don't have periods, because they normally have higher prolactin. If you do excessive exercise, quite often this will be elevated, and by excessive, I mean like professional level athleticism, doing lots of long distance running or anything excessive, basically. Sometimes this can raise your prolactin and have an impact on ovulation. And then androgens. Now, these are the male hormones. And actually, whilst you might think, well, why are we talking about male hormones for female fertility testing? This is actually really important. So when your eggs are being matured, recruited, and prior to ovulation, the balance between the female hormones, so the estrogen, and the male hormones needs to be really well balanced. If you have too much of the male hormone, or what we call a raised free androgen index, this can really play havoc with getting pregnant. It will really affect your egg quality, and it's more important than you might realize. If you have high levels of male hormones, it might be having an impact on your cortisol as well, your stress hormone, and also your sleep quality. So male hormones, there's a few. You've got testosterone, you've got something called sex hormone binding globulin, or shortened to SHBG. And then together combined, this gives you your free androgen index. So again, quite important if you think that polycystic ovaries might be an issue for you. This would be the first point of call to get your androgens checked. It's possible to have a type of polycystic ovaries where you don't have the elevated androgens, but quite often there'll be some imbalance there. So this is why women with polycystic ovaries sometimes have bad skin or slightly excess body hair, because the male hormone level is too high. So again, really important to get checked. Testosterone, massively important. This can be affected by something called DHEA. So if you have low levels of DHEA, then you may have low testosterone. So again, all these things, egg quality. So those are the tests that you would get done between day 2 and 5 of your cycle. So by that, I mean your day 1 of your cycle is day 1 of your period. So any time between day 2 and 5, so often while you're still on your period, is the key time to get these checked. And then the next test we're going to talk about is one that is commonly referred to or tested on day 21 of your cycle. So this is progesterone. So now, ideally, progesterone needs to be tested 6 or 7 days after you ovulate for the most accurate result. Often a GP will say it needs to be done on day 21. However, if you're ovulating much earlier or later than day 14, then you're having your progesterone tested on day 21, the result might be inaccurate. So it's really important to work out exactly when you're ovulating before you have your progesterone checked. The GP will always say to you day 20, day 21, and that's just not the case for everyone. You can check when you're ovulating by either using the ovulation predictor sticks, but also checking your cervical mucus. So if you're getting that stretchy egg white mucus, that normally comes a few days before you ovulate, and also tracking your basal body temperature. So those three things together can help you work out when you're ovulating. So progesterone is measured primarily to check whether ovulation's occurred. So if ovulation has occurred, your progesterone level will rise. It's secreted by the leftover sac when ovulation occurs. The leftover sac, called the corpus luteum, releases progesterone. So if that progesterone is at a certain level 6 or 7 days after you've ovulated, then we know that ovulation's occurred. It also needs to be a certain level to maintain pregnancy. So progesterone is really important for implantation and the uterine lining. So if your progesterone is low, then it may mean that perhaps your egg is being fertilized, but you're not achieving implantation, or you're having very early losses. So this is really important to get checked. And it's worth bearing in mind that if your progesterone level is below 30, you can ask your GP for some progesterone supplementation. They won't always be keen to do this. Progesterone can be expensive to prescribe, but more and more GPs have read the evidence regarding the importance of progesterone for pregnancy, and therefore they're more likely to become more open to it over time. So if you're having a bit of a dialogue with your GP, if you think this might be an issue, there's lots of evidence that you can find online of studies that show the importance of progesterone for early losses, and that should be enough to present to your GP to ask them to test this. I actually often get progesterone checked in the very early stages of pregnancy with any of my clients that have suffered with low progesterone. It's just so important to maintain pregnancy. You can also use exogenous progesterone cream, which you can order online, and progesterone pessaries, that also the cyclogest pessaries that if you've had IVF, you'll probably have used, but you do need a prescription for those. You can't just buy those online. And then anti-Müllerian hormone, next test. So this can be, I think this can be checked anytime. I may stand corrected on that, but this is such a controversial hormone. So, and a lot of women will come into my clinic and they will say, I've got low AMH. I've been told that egg donation is my only option, or that IVF is an option, but I've been told not to expect to have many follicles or many eggs retrieved. So it's really important to know that fertility clinics will check AMH in order to work out how well you are likely to respond to IVF drugs. So if you have a lower AMH, it may mean that you don't respond as well to IVF drugs. It doesn't mean that you won't get any follicles or any eggs, but it may be the deciding factor for the clinic as to whether they decide to treat you or whether they decide to recommend that you use donor eggs. So having a low AMH doesn't mean that you can't conceive naturally. It doesn't mean that you can't conceive with IVF. The main reason clinics check this is to work out your likelihood of success, and again, whether they choose to go ahead and treat you. The evidence shows that actually using AMH alongside something called an antral follicle count, which we'll talk about more about how to get checked shortly, but using an antral follicle count alongside AMH is a better predictor of overall fertility and IVF success than just using AMH. And you'll see on the chart here, I've got some age ranges and then what your AMH what we'd like your AMH to be for your age range. So, for example, if your AMH has been tested and it sits at 7.9, which you'll see towards the end of the chart, but you are only 36, then that means that your kind of fertile age is probably more like 40. But you mustn't take that as just that. It needs to be checked, like I said, with an antral follicle count. And this is a check of how many follicles you're producing in a cycle, and then used as well alongside your follicle stimulating hormone and your luteinizing hormone to form an overall picture of your fertility. There's so many other factors involved that are vital for fertility. So egg quality, the uterine environment, they're just as important. It's not just about egg numbers. We know that you're only going to ovulate once a month. You're only going to have a certain number of eggs. We're born with all the eggs we need. It's no surprise to us that they decline over age as we get older. Your egg reserve will always go down. It's about looking at the overall picture, and really important to remember that you can still conceive naturally with a low AMH, providing all of the other factors that come into play have been assessed and are balanced. Let's just flick over, but yeah, AMH can be checked at any time, I believe. And then finally, as part of the more basic hormone profile testing, is thyroid stimulating hormone, or TSH. So your thyroid is really important for fertility. It controls so many of your bodily functions, so mainly metabolism and growth, and low levels of TSH can also stop ovulation, and thyroid imbalance has been linked to early miscarriage. And a full hormone profile would really be ideal. So not just getting TSH tested, but also your free T3 and your T4. It's possible that your thyroid stimulating hormone can come back normal, but that you have a slight imbalance with the conversion of some other hormones that can have an impact. And we'll talk a little bit more about thyroid antibodies when we come to immune testing. An underactive thyroid is much more common than an overactive thyroid. It's really easily treatable, normally with something called thyroxine. And there's a bit of kind of disagreement really in terms of what the ideal level for thyroid hormone should be. So new evidence and more recently fertility consultants kind of following this, new evidence shows that your TSH really needs to be under 2 to maximize conception. So if you go to the GP and have this done, anything under 4, sometimes 5, they will class as normal. However, a fertility clinic would often like to see you under 2.5. Some endocrinologists, which are people that specialize in the endocrine, the hormone system, some endocrinologists will tell you that really it needs to be under 1 for fertility. So I think the general consensus needs to be that anything under 2.5 going into fertility treatment or for natural fertility would be ideal. Certainly anything over 2.5 could have an impact on implantation and potentially leave you at high risk for an early miscarriage. So really important to get your thyroid checked as well. So that is all of our basic level hormone testing that I'd recommend, but it's not all about your hormones. So what about if something physical might be happening that's stopping you from getting pregnant? So if your hormone tests come back normal, then I would move to looking at more physical issues. This doesn't mean that you can't have a physical issue as well as a hormone imbalance. So first of all, your fallopian tubes. So going back to the fertility pinch points that we talked about, we need to make sure that that egg is able to be reached by the sperm and then able to travel down to the uterus. So if you have blocked fallopian tubes, that could potentially be being hindered. You can have this with no symptoms at all. Sometimes women get abdomen pain, but yeah, it can go missed quite easily. So again, if there's, issues going on and you can't work out why you can't conceive, this would be something worth getting checked for sure. So there's 2 ways to check this. You can have something called a HSG, which is where they put radioactive dye into your fallopian tubes and then they x-ray you, and they can then see any blockages on x-ray. It's local anaesthetic, done between days 5 and 12 of your cycle. A few things that are important to know, that it's quite high in terms of radiation, so the equivalent of 10 x-rays. Once you've had it done, it will increase your chance of natural pregnancy for a few months afterwards, as the dye effectively washes out your fallopian tubes. And it's quite often combined with a laparoscopy, which we're going to talk about shortly. And this is often known as a lap and dye. Might be something you've heard discussed by a fertility consultant or GP. The second way to check is something that's becoming used more often, I think probably because it's a little bit more gentle, something called a hycosi. And this is where they use sugar water rather than radioactive material, and they inject that via the uterus into your fallopian tubes, and then they use an ultrasound to look for any blockages. So it's not as accurate as a HSG, but certainly clinically I've had people that have had things diagnosed using it. It's just not quite as accurate as a HSG, but obviously involves doesn't involve rather the use of x-rays. And then endometriosis. So endometriosis is something you can have and have no symptoms. Often the first sign of endometriosis is infertility or struggling to conceive, and it can take up to 8 years sometimes to diagnose endometriosis. So it can be totally symptomless, but there are also some subtle signs that your body might give you that it could be a possibility and it might be worth exploring further. So if you ever have any pain during sexual intercourse, or any pain when you open your bowels, or if you get that like lower back pain or leg pain that goes down the front of your legs around your period, certainly period pain that requires a lot of pain relief would be a key marker. Particularly heavy or clotty periods that start with a few days of that brown cluggy discharge, or any discharge or spotting that's coloured between periods. Sometimes loose bowels or like irritable bowel type symptoms around your period. And then infertility, key symptom. Again, I've had so many clients that this is the first sign that they've got endometriosis, that they're struggling to conceive. If you do chart your basal body temperature, then checking this can give you an idea as to whether endometriosis is an option. Often your temperature doesn't drop down before your period arrives. So if you've got any of those symptoms and you're struggling to conceive, then definitely worth pushing for some further investigations. So on the NHS, your GP will refer you, and they tend to do a laparoscopy, which I'll come to in a second. But privately, and maybe on some primary care trusts, you might be able to get an MRI, but an MRI is kind of like the gold standard. It's non-invasive, so it's non-surgical, and it allows the consultant to see pockets of endometriosis and to grade it. And also it means that if you don't have endometriosis, so you've gone for an MRI, you don't have it, then you haven't put yourself through a surgical procedure unnecessarily, because the only other option, which I'm about to talk about, is a surgical procedure. But if you've got any of those symptoms and you are struggling to conceive, then I would definitely recommend having a chat with your GP or seeking out a private fertility specialist and having a chat about whether this might be a consideration. So next up is a laparoscopy. So this is the more invasive way of checking for endometriosis, but it's actually both diagnostic and a treatment. So a laparoscopy is carried out under general anaesthetic, and a fibre optic instrument is inserted through your abdomen, and they have a good look at your uterus and all around your pelvic cavity, and they can check for endometriosis or anything like fibroids or polyps, or any internal scar tissue, anything that's going on in there, they can generally see with a laparoscopy, but they can also remove anything that's causing an issue. So polyps, fibroids, any endometrial deposits or tissue. So again, it's kind of kill two birds with one stone, for want of a better phrase. They can go in and diagnose, but also treat the issue at the same time. And then really important to remember that endometriosis will always return. You'll have a time frame after having the surgery, normally up to around a year, where you will potentially, if you've been having symptoms, be symptom free, but certainly have improved fertility. There's lots more involvement with endometriosis, and more evidence now shows that it may be linked to the immune system. Certainly it will have an impact normally on your progesterone levels. So it's not just a case of having it removed. There are other things to look at as well, but a laparoscopy will certainly help your chances of conceiving if you have endometriosis. And then the final kind of, I guess you could call it a semi-surgical procedure, is a transvaginal ultrasound. So this is the infamous Wanda, the probe that is inserted vaginally. And using this, they look at your uterus, your ovaries, and your vagina. And commonly, this is used to diagnose or help diagnose polycystic ovaries. So if you have PCOS, or you think it might be an option. So for example, if you've had those first hormone tests completed and you've come back with high androgens or a high AMH, which I didn't mention, but women with polycystic ovaries often have a really high AMH for their age, high estrogen or high luteinizing hormone, then you might have polycystic ovaries. So again, transvaginal ultrasound, have a look at your ovaries, see whether there's any cysts there, really easy to help diagnose. But also we talked about an antral follicle count used alongside AMH to look at fertility. So this is how they would look to see how many follicles you're producing. So between days 2 and 5 of your cycle, when your follicles are just developing, the consultant will perform an ultrasound and be able to see how many eggs you've got in the process of developing, or how many follicles on each ovary. And then they use that to help predict your ovarian reserve, but they must do it alongside your AMH, your follicle stimulating hormone, and your luteinizing hormone. And this chart here will give you an idea of what sort of age, like fertile age you are. So for example, if you have an antral follicle count of with both ovaries combined of say 6, and you are in that age 30 bracket, then you can expect your fertility, natural fertility, to decline earlier than perhaps someone else, so between 29 to 33. Again, this is not set in stone and needs to be used alongside other things as well, but gives you a little bit of an idea. And then we are going to talk about some more complex things. So that's the end of all of the kind of basic level investigations, both blood test wise and surgical wise. But what about if you can get pregnant, but sadly you're suffering with recurrent losses, or you've already started IVF and you're having recurrent IVF failures? Going back to that initial fertility pinch points diagram, we're really looking at these last 2 stages. So is your uterine lining receptive to an embryo? Is there sufficient blood flow to the embryo and the placenta? And is your immune system allowing a pregnancy to happen? So providing your hormones are balanced and your egg quality and your sperm quality has all been checked out, then reproductive immunology is something that could be looked at as being an issue. It's a bit of a controversial area of fertility. So some of the evidence suggests that the immune system doesn't really play a part in fertility. However, there's also lots of evidence to suggest that it does. So some consultants will totally dismiss reproductive immunology. Others will sit on the fence, and others will base their entire clinical protocols around reproductive immunology. So if you decide to go ahead with the testing, it's really important that you find a consultant that will actually be able to treat any potential issues. There's no point going for the tests if you're under the care of a consultant that doesn't believe in reproductive immunology. You would have to change clinics in order to probably get the treatment that you need. It's also important to know that you can go for these tests yourself. So there is somewhere in Surrey called the Reproductive Immunology Centre, and it's the only place in the UK where you can have these tests done. You'd need to be referred either by your consultant or any of the acupuncturists who work with the fertility support company can refer you, and we'll pop some more details of that at the end. But it's important to know that you can go and get this tested. So here I've got some ideas about when you might consider getting tested. So these are just guidelines, and I've adapted these from a book which some of you may have read. It's called Is Your Body Baby Friendly? And it's a book by a guy called Dr. Alan Beer, and he talks a lot about the effect of the immune system on your ability to get and stay pregnant. So these are kind of some of the key factors. So I'm not going to list them all, but if you have had repeated IVF failures or recurrent losses, certainly, you know, one miscarriage or IVF failure after 35, or two miscarriages or IVF failures before the age of 35, then this is definitely something that needs to be considered. If you look further down the list and you can tick other things on this list, then that just adds weight to the argument that it might be worth looking at getting tested. So all of these things that I've listed effectively increase the chance of reproductive immunology being an issue. And certainly, of course, if you've got any autoimmune diseases, so these might be things like lupus or rheumatoid arthritis or Crohn's or something called Hashimoto's, which is a thyroid disease, or if you have a family history of any autoimmune disease. So all of those things can really have an impact on whether you would perhaps decide to go and have reproductive immunology tests. Another thing that I don't have another slide for, but is blood clotting disorders. Now, these are actually quite rare. You've got things called factor V Leiden or antiphospholipid syndrome, and these can be tested on the NHS. So just to backtrack a bit, these reproductive immunology tests, they can't be done on the NHS. However, certain other tests can be done. The NHS can test for certain parts of immune factor. So they can test for things like lupus antibodies, but they can't do a full immunology, what they call assay. But the clotting disorder tests can certainly be done on the NHS. And if you have been referred to the recurrent miscarriage clinic, these are normally the sorts of tests they would do looking for blood clotting disorders. But sadly, the NHS say that you have to have had 3 or more losses. But these are more rare in terms of their likelihood. And then something which I haven't got a slide for because it's still relatively new and I just haven't updated my slides yet, but another area of testing that's become much more advanced is the ability to check the receptivity of the uterus. So again, going back to the pinch points, in fact, I will go back to that now. So going back to these fertility pinch points, so really this stage here, so when implantation is occurring, there's some tests that can be done to check the receptivity of the uterus, and they're going to be looking at whether there's any inflammation or infection that might be stopping implantation. So there's 3 tests that tend to be considered, and these are the ERA, which stands for the endometrial receptivity assay, the EMA, or the ALICE tests. So what's the difference? So the ERA will test the implantation window, and it works on the basis that IVF might be failing based on the window of implantation being different in some women. So this test will enable your consultant to return an embryo at a time that your uterus is potentially at its most receptive. So again, evidence shows that this is not the same for each woman, and in an IVF cycle it can be timed, embryo transfer can be timed to maximize your chances. The EMA test looks at the bacterial environment of the uterus, and it assesses whether there might be any bacterial imbalance between, I guess, healthy and bad bacteria that might be stopping implantation. And nowadays, more women are being treated with antibiotics to clear up any low levels of infection in the uterus lining. And then the ALICE test looks for inflammation within the lining. And again, this is often caused by bacterial infection, but inflammation is called endometriosis. And this could affect whether your lining is thick enough for implantation, or whether you have the ability to produce the what they call the triple layer lining, which is key for implantation. So these three tests can all help determine what's going on inside the uterus and really how receptive your uterine lining is for implantation. At the moment, as far as I'm aware, those tests are only done by private fertility clinics and not on the NHS. So as you can see, that's a lot, really, and I haven't even really talked about sperm testing. Again, that's a whole nother webinar, and how to balance your hormones to maximize egg quality. But apart from those two things, there's lots of things that you can get checked and to be tested to help you get to the bottom of why you're struggling to conceive. So some of them are available freely on the NHS, some are private and expensive, but ultimately I think it's about assessing where you are in your journey, looking at your overall health and your case history to determine a priority for what needs to be tested. So by getting to the bottom of things before you go into fertility treatment, you're going to hugely increase your chances of success, and your treatment can then be tailored to your individual case. So if you get something diagnosed, you therefore get the right treatment. And there's no one size fits all when it comes to fertility. Any clinic that just does a standard protocol for every patient, I would steer well clear of. And having these tests, although they might cost you money in the short term, in the long term, they potentially could save you failed treatment rounds, or even to avoid having any fertility treatment if you can work out what's going on. And it might save you a lot of money and heartache in the long run. So this is kind of where I work. I work a lot with women to get to the bottom of what's going on with their fertility and get the correct treatment. So I use acupuncture and lifestyle advice alongside all of these Western diagnostics to help you either avoid the need for fertility treatment or to increase your chances of success if you do need it. I've worked with lots of women that have had repeated failed treatment rounds. And they take a break for 6 months. We put the time in to do the testing, to make the lifestyle changes, and really to nail down what's going on. And then when you go back into a treatment round, potentially, then you are in a much better place in terms of being able to tailor the treatment to suit your specific diagnosis. So yeah, that's kind of everything from me. I am just going to come off the screen sharing so you can see my face again, and then I'll see whether there's any questions.
Thank you so much, Rachel. You covered a lot of ground there. That was super informative and thorough and clear. So I really appreciated that. I'm sure others did too. We did have one or two questions come in the chat box, so maybe I'll start by putting those to you.
Go for it.
And then if anyone wants to type any others in the meantime, then I'll keep an eye. Just when you were talking at the beginning, there was a lot of tests, androgens, AMH, luteinizing hormones. You touched a little bit on NHS or private, but what are the actual tests? What do they involve? Are they blood tests? Can you have them all done at once, or are they separate tests?
So the tests that I talked about between days 2 and 5 of your cycle, so those ones I talked about first, they're all blood tests, and your GP should be able to do all of those. So some GPs will perhaps only do 2 or 3 on that list as standard. However, they really need to be checking all of them. If your GP refuses to do them for any reason, which I have heard of, or you've had them done and you haven't got all of them, but you can't be bothered to go back to the GP, or there's a long waiting list, then you can get them done via a company online called MediChecks, and it's a finger prick sample test. It's really easy. I use them a lot with all of my clients, and it's a postal service. And you use the little lancet to finger prick your end of your finger, sample the blood and send it back, and they will then send the blood test results back to you, and they're really good. So where there's a will, there's a way. You can always get them done privately, and they're not expensive really. I mean, obviously it's a bit frustrating when you know you can get them on the NHS if you're meeting some resistance, but in terms of, you know, the cost of some fertility tests, they're really not that expensive. So yeah, so those first ones I talked about, and then the investigative procedures, they're surgical procedures, if that makes sense.
Great, thank you. And then you referenced some research around the progesterone that you might be able to use to make your case. Have you got a link, or do you know where people can access that?
Yeah, I can send a link and then you can pop it up. I haven't got it handy at the moment, but I've got it saved on my laptop. So let me just make a note that I remember to send that.
And then one other question that's come in, my GP did the tests, but all at the same time as the day 21 progesterone test. Should I have the earlier tests redone at the correct time of my cycle?
Yeah, so it depends who's interpreting them is really the answer to that. So if you're happy that your GP knows their fertility stuff, and you're happy they've been interpreted properly, which I know is really hard to tell, then they wouldn't need to be redone. If I was checking them, I would have them done separately. I would go into probably more depth than a GP would and be looking more closely for any imbalances, and I would definitely prefer to have them done separately. Also, we need to be clear with that. If you've had all those tests done on day 21 of your cycle, we need to be really clear when you ovulated, because if you didn't ovulate on day 14 and you had the tests done on day 21, then they may be inaccurate. So it's really no point having a test, certainly for progesterone, on day 21 if you ovulated on day 19, or if you ovulated on day 10, that you're not going to get an accurate result. So the progesterone always needs to be tested 6 or 7 days after you ovulate. So worth bearing that in mind. I would probably get all the other tests apart from the progesterone redone between days 2 and 5 of your cycle, for sure. And then I would be taking them to a fertility specialist rather than just letting the GP have a look at them. With anything medical, and this goes not just for fertility, always get a second opinion. A doctor is, you know, often good at what they do. However, things get missed. People don't specialize in everything. It's impossible for a GP to specialize in everything. A second opinion doesn't hurt anyone. Things get missed. You know, this is life, and you know, a doctor is human like the rest of us, and mistakes happen. And I think, yeah, just get a second opinion for sure.
And just working with the resident experts on Fertility Circle, I've really seen like the kind of absolute leap in knowledge and experience and expertise. It's actually quite, you know, daunting, like just how much there is to know. And, you know, a GP is a general practitioner, they can't know everything. So yeah, look at our resident experts in our app as well, because we've got some real world leading experts there. Brilliant. Well, I have posted your website, oxtedacupuncture.com, into the chat. So if anyone wants to follow up, you can go via the app to reach out to Rachel, or you can link on your website. And Rachel, did you have something to add?
Yeah, so just to say that if anyone's got any other questions, I'm happy to answer them over email. And I also you know, I used Instagrams. You can direct message me on Instagram. Yeah, just I think the most important thing is just to remember that, you know, educate yourself and empower yourself to take control of your own fertility, and, you know, use all the resources like the Fertility Circle app. There's so many amazing practitioners out there willing to help, and have knowledge that, you know, to specialize and help you, that take advantage of them, use them, and if you feel like something's not quite right or something needs a little bit more investigation, then usually follow your gut, and it's worth following that thought process. But yeah, that's kind of all I've got to say, really.
Fantastic, thank you so much. If anyone wants to recapture some of what we discussed today, it will be available in the playback section of our events, so you can revisit it there. And as she mentioned, her email and social media links are going to be in her bio as well, under our expert section. So do reach out. I hope that's been of use. I certainly learned a lot. Thank you so much, Rachel. That was really clear.
You're welcome. Nice to see you. Thanks for having me.
Thank you. Take care.